All right, next we're going to talk about the neurologic exam. There are 6 components to the neurologic exam. First is cognitive function, cranial nerves, then motor, then sensory, deep tendon reflexes, which I always find is amusing because on the neuro unit, I would challenge you to find a reflex hammer, but we'll move on from there. And then most importantly, or equally important, is coordination, and gait is probably the best assessment of coordination that we have. So in the critical care unit, we often, and in the emergency and trauma units, we're often faced with patients who don't have full neurologic function, and so the Glasgow Coma Scale is useful. Remember that the lowest possible score is 3. All right, so even if the patient is shall we say, in extremis, the lowest score that they'll have is 3. The best response is 15, and you should know that the comatose level is less than or equal to 8. All right, that's kind of our definition for comatose. And we have 3 components to this: the best motor response, best verbal response, and then eye opening. So all you have to do is figure out where the patient comes in the best motor response. If they obey commands, then that's a 6. And then you look at their best verbal response. If they are confused, then they get a 4. And if they open their eyes spontaneously, they get a 4. So we just add these up, and that's your Glasgow Coma Score, or GCS. Arousal is a complex neurologic function that includes structural details. So, if you don't have the reticular activating system, then you can't be aroused. You have to have metabolic functioning. So if you have hepatic encephalopathy, for instance, that is a metabolic reason that you won't be arousable. And then there's psychogenic alterations as well. So there are patients who have psychogenic fugue, for instance, or they have stupor for some psychological reason or psychiatric reason. So there are different levels that we have to address. The first level of altered consciousness is confusion, and that's impaired judgment and decision making. That progresses to disorientation, then lethargy, then obtundation, which is mild to moderate reduction in arousal with limited response to environment, stupor, and then finally coma. So patients exist somewhere on this continuum, although total health is not shown on here, but these are the levels of altered consciousness in a continuum. Now, another assessment that we can use in the critical care unit or wherever, I don't know why I said critical care unit, except this is a critical care course, is the respiratory pattern. So you see a normal respiratory pattern shown at the top, and then there's obstructive types, and then there's bradypnea, which is slow breathing. That can happen because of, let's say, opiate use, for instance. There's also Kussmaul's respirations, which is fast and deep respirations. We see that in metabolic acidosis. And then there's other ones as well. And you probably have heard of Cheyne-Stokes, which is intermittent, fast breathing that later slows down and becomes apneic at some point. And that happens in brain damage, also in heart failure, in severe heart failure. We can see that as well. Another function or abnormal function, dysfunction that is, that we see is pupillary responses. And I don't expect you to memorize these or have them all committed to memory by any means, but I do show you this so that you can see the location in the brain stem that is responsible, or I should say in the primitive brain, that's responsible for some of these abnormalities. One of the things that we use to assess patients is this test called doll's eyes. Now, when I first learned about doll's eyes, I thought that they were talking about the doll that when you sit the doll up, the eyes open. When you lay it down, the eyes close. But that's not what this means. What doll's eyes is imagine a doll that has the eyes painted on. They don't move their eyes at all. And that's the doll's eye response. So this is 3 different representations of what happens when the head is turned. The normal response is that the patient continues to focus on something straight ahead. An abnormal response is that the eyes don't turn together. And then absent response is that they don't turn at all. All right? They're doll's eyes. That is, they're painted on essentially, and they're always looking straight ahead no matter what position the head is in. The eyes don't change. That's the absent response to doll's eyes. Another test that we see that's often very dramatic is this oculovestibular reflex, and this is essentially taking ice water and injecting it into the ear canal. And what should happen if the patient has normal brainstem function is that the eyes should move toward the offending procedure, right? So the eyes look toward the noxious stimulus. An abnormal response is disconjugate movement, where one eye moves away, one eye stays focused forward, as you see in B here. And then an absent oculovestibular response is no eye movement at all. Posturing, we've all heard about. So there's decorticate response, which is shown in A, decerebrate response, which is shown in B. But you can also have mixed response, where you have decerebrate on one side and decorticate on the other, and those are pictured here. So what are the outcomes of an altered arousal state? Well, there are several. One of them is a persistent vegetative state. So if the patient survives their injury in a physical sense and never recovers any brain function at all, they have a complete unawareness of what's going on with themselves and in their surrounding environment. They have no cognitive function at all. That's called a persistent vegetative state. And that's where the body is alive, but there's nothing going on inside the brain. There's also somewhat less severe, although we could argue whether it's truly less severe. Akinetic mutism is a very severe disturbance in behavioral drive. So these patients aren't able to do anything on their own, but they can track things with their eyes, and essentially the only arousal state that they have is the ability to open their eyes. There's also this thing called a minimally conscious state, where they have evidence of some self or environmental awareness. They can follow very simple commands and move things that are put in front of them. Sometimes they can do yes or no responses, but that's really all that there is to it. And then the most horrible of all these states, I think, is the locked-in syndrome. And this is essentially what would happen if you had severe brain injury, but you have preserved if you have severe brain stem injury and primitive brain function is lost, but you still have the cerebral function. This is where you have no ability to respond to the environment except in eye movement, and you know everything that's going on. You can't move a muscle. You can't do a thing. but you know everything that's going on. And it's a very difficult thing to assess if patients even know what's going on, because how do you get them to tell you, right? So we rely on some diagnostic testing like functional MRI and things like that, but it's a very, very difficult thing to do, to assess. There are data processing deficits that you remember talking about in previous coursework. One of them is agnosia. So there are different kinds of agnosia out there, but it's a defect of pattern recognition. Stereognosia, we're going to talk about later on, for instance. Dysphagia is an impairment. Dysphagia is an impairment of either comprehension of language or production of language. Language by itself is a very complex thing. So there are components of it that require speech, but there's also a part of language that doesn't require speech at all, right? You read, for instance, and that's using language, but it's a different kind of language. So sometimes these patients have an inability to understand what you're saying because they have this receptive aphasia. But if you write it down for them, they can understand that perfectly. And so this is one of the really fascinating things that you see with patients who have brain injuries due to stroke or head injury or what have you. They have these very interesting dysphasias that happen. There's something called an acute confusional state, which is an altered mental status, but then they have severe agitation, very, very strong. They're non-compliant. This is a medical emergency when patients have this EDS, or excited delirium state. And this can be caused by drug use, for instance. But I've seen it a couple times, and it is terrifying. I mean, it's very, very hard to subdue these patients and bring them under control. And then there's also a hypokinetic confusion state, which is what we are what we're accustomed to seeing. There's dementia, which you've talked about before and should know well about that. There's also that doesn't even make sense, but you should certainly understand dementia. There's also this thing called frontotemporal dementia, which is a particular kind of degenerative disease of the frontal lobes. And it's hard to distinguish that from Alzheimer's disease. And Alzheimer's disease, of course, is the last of the data processing deficits listed here. Remember, there are 12 cranial nerves, and so this table sort of breaks it down for you so that you know what you're testing for and what each of the nerves does. After we assess the cognitive state and the cranial nerves, then we move on to either the sensory or the motor exam. It's up to you. I typically do the motor exam next. Remember, we evaluate this on a 0 to 5 scale, with 5 being the strongest. And we test the trunk, the upper extremities, and the lower extremities for strength here. We also test the neck, but we do that back here under the cranial nerves, right? For the spinal accessory, we have the patient turn their head and resist, you would resist their head movement with your hand to test their strength. So motor examination is pictured here. Also, the other thing I want to point out to you is if you have somebody squeezing your fingers to test their strength, don't put your fingers side by side and give it to them, because that can really hurt you. But while you're listening to this, just cross your fingers one over top of the other one and squeeze as hard as you can. You can tolerate that without any problem. But side to side, when your knuckles hit together, that's very painful. So I just give you that little clue that if you do that, you'll avoid lots of pain with some patient in the emergency room who's trying to hurt the young, nice nurse. I don't know why they would do that, but it happens. As I alluded to at the beginning, there are many different sensory functions that the brain does. One of them is proprioception, as I mentioned before. Proprioception is that ability to know where your body is in space. So I don't know if you've ever woken up in the morning and you're just starting to wake up, you're laying there, and it occurs to you that you have no idea where how your legs are positioned or your body is positioned. You have no idea because your proprioception is lost. Now, all you have to do then is move a toe or move a finger, and you know exactly where your body is in time and space, right? And that is proprioception, the ability to know where your body is and how it's arranged. Other sensory exam things include light touch. That's the easiest one, right? Hot and cold discrimination, 2-point discrimination, stereognosis, which is shown here with the key in the hand. So just feeling the key with your eyes closed, knowing that it's a key, that's easy to do for most people. Graphesthesia is where you draw a letter or a number in somebody's hand and ask them what that is. And then there's extinction as well. Dermatomes are important to know because of their ability to tell us what level an injury occurred at, right? So we use dermatomes for a variety of things, but knowing that C5 injury, for instance, will produce loss of this radial, what's the word I want? The radial distribution here, or a C6 injury will actually cause loss of thumb function. That's useful information to localize the injury itself. All right. Earlier, I talked about upper motor neuron lesions, and there are upper motor neuron lesions, which essentially involve the central nervous system, and there's lower motor neuron lesions, which essentially involve the peripheral nervous system. The importance of knowing this is that there are different things that happen. Let me rephrase that. The importance of knowing about upper motor neuron lesions and lower motor neuron lesions is that they are pathognomonic. They tell you essentially what problems a patient may potentially have. So for instance, CVAs, whether they're thrombotic or hemorrhagic or whatever, those are always upper motor neuron lesions, right? Because they affect the brain. But how about things like ALS? Notice that ALS is listed on the lower motor neuron lesion side, but it's also listed on the upper motor neuron lesion side. And in fact, that is ALS. It is a combined upper motor neuron lesion and lower motor neuron lesion. So essentially, upper motor neuron lesions have the inability to have the peripheral nerves communicate with the brain, either because there's been a stroke, or there's a tumor there, or there's some problem with the cord that prevents the transmission of that signal. We're going to come back to that when we talk about some of the physical findings like we talked about earlier, which is the reflex arc. But before we do that, I want to talk to you about one of my favorite hobbies. This is I love photography, and this is a famous photographer who took this photo. His name is Henry Cartier-Bresson, and his deal was this thing called the decisive moment. And if you look at this picture, this is one of his most famous photos, and I actually have it hanging in my office. You can come see it there if you want. The cool thing about this photo is that if it was taken a split second later, this photo wouldn't be at all interesting, right? I mean, he'd land in the puddle and you're like, okay, so he jumped in a puddle. If he took it a second earlier, it wouldn't be interesting because there's no interest in him standing on that ladder, right? But the decisive moment is that he's about to land in that and everything's going to change, right? It's exciting. this is also a decisive moment. Now, I know you're looking at this thinking, yeah, it's a picture of two kids, right? Well, there was a physician who published this in the New England Journal of Medicine a couple of years ago. Well, many years ago. And I just love this picture because this is the decisive moment when this little 18 or, 1-year-old or whatever, he's probably not even one. I don't know. I can't tell kids anymore. Mine are all grown up. He's probably, let's say he's 6 months old. So what's happening is he's touching the plantar aspect of his foot, of his left foot with his right toe. You see that? And at that very moment, his toe goes up, his big toe goes up. And that's the Babinski response. And you know that the Babinski response is normal in kids up to 18 months or so. But this is the Babinski response. So all that other stuff that you learned about the toes fanning and this one going up and this one going down and whatever, that's all BS. This is the Babinski response. It is the great toe going up. Forget all the other stuff, all right? I don't care about the fanning. I don't care what the other toes do. The big toe going up is the Babinski response. It is abnormal in adults. It's abnormal in people over 18 months old. But some patients have it sort of as their normal, right? And so it's important that we know what a patient's response is, prior to their injury, if possible. Now, why am I talking about this with upper motor neurons? Well, because it's an upper motor neuron lesion that causes the Babinski response to happen in grown-ups. So when you see an upgoing toe, that's the Babinski response. And I'm sorry, I should say that when you see an upgoing toe in response to touching the plantar aspect of the foot, that's a Babinski response. And that's associated with an upper motor neuron lesion. There's two other things that are associated with an upper motor neuron lesion, and one of them is hyperreflexia. And so this is a patient who's hyperreflexic. Look at that. She's almost kicking that guy in the nose. I mean, that's incredible. And then so when we grade responses, we grade them on a 0 to 4 scale. 0 is no response. 4 is what you just saw there. Most people have a 2/4 reflex response. And then the other thing that happens with upper motor neuron lesions is clonus. And this is an example of clonus. When this foot is hyperextended quickly, you see that it pulsates back and forth like that. And that prolonged pulsation is prolonged clonus. Lastly, the other thing that we do is evaluate coordination, and gait is among the most complex tasks that the body does. When you look at coordination, that gives you a really good idea of a patient's abilities, their ability to process instructions, and their ability to have their cerebellum participate in coordinating their efforts.